The objective of this talk is to learn about the definitions of acute renal failure, causes of renal failure, hepatorenal syndrome, diagnostic evaluation, and management of hepatorenal syndrome and prevention of acute renal failure in the setting of cirrhosis. I have nothing to disclose. This is a cirrhotic liver, and the complications of cirrhosis are hepatocellular carcinoma and complications of portal hypertension, which includes variceal bleeding, hepatic encephalopathy, hepatorenal syndrome, ascites. Before liver transplantation was the standard of care, the treatment for cirrhosis was hospice. However, after the discovery of cyclosporin, liver transplantation became the standard of care. Patients with cirrhosis and complications of portal hypertension can be listed for liver transplantation. However, currently there are 17,000 patients listed for liver transplantation. Approximately 6,500 get transplanted every year. 15 to 20% dies while waiting on the transplant waiting list. Once they are on transplant waiting list, they get transplanted. As you know, the 1-year survival after liver transplantation is 90%, and the 5-year survival after liver transplantation is 75%. So still a number of patients died after liver transplantation. And they can die of graft failure, disease recurrence, cardiovascular comorbidities, renal failure. Some of these patients with disease recurrences can be relisted and get retransplanted. So in this talk, we will focus mainly on hepatorenal syndrome and acute renal failure. Before going into the details of acute renal failure, let us refresh the basic principles involved in the management of cirrhosis. The development of ascites in a patient with portal hypertension is the result of increased renal retention of sodium and water. Patients whose urinary excretion of sodium is significantly less than dietary intake will accumulate sodium and water, and eventually leading to ascites and peripheral edema. The mainstay of treatment of ascites in most of these patients is combination of salt restriction, mainly to 2,000 mg per day, and diuretics. The diuretics of choice are furosemide and spironolactone in the ratio of 40 mg to 100 mg to maintain normal kalemia. Once the patients are on diuretics, their electrolytes and kidney functions needs to be monitored very closely. And once a patient develops ascites, they need to be referred for liver transplantation because after development of ascites, the median survival ranges from 6 months to 2 years. The common complications of diuretic use include dehydration, renal failure, electrolyte imbalance, and one of the most common is hyponatremia. In this slide, we will talk about the management of hyponatremia in patients with cirrhosis and ascites. Usually, patients with cirrhosis and ascites are asymptomatic when they develop hyponatremia unless the decline is rapid or serum sodium is below 110 millimoles per liter. Fluid restriction, if serum sodium is less than 125, usually brings up their sodium. Hold the diuretics if the patient is dehydrated. Consider treatment if patient has neurological symptoms. However, the rate of correction should be less than 10 milliequivalents per liter at 24 hours and less than 18 milliequivalents at 48 hours. Rapid correction of sodium would cause central pontine demyelination. Now, creatinine is a breakdown product of creatine phosphate in muscle. Based on muscle mass, it is produced at a constant rate. Because females have lower muscle mass than males, therefore they tend to have lower creatinine than males. For the same reason, patients with cirrhosis who also have lower muscle mass and poor nutritional status tend to have lower creatinine. The spectrum of renal dysfunction in patients with cirrhosis varies from slight elevation in serum creatinine to full-blown renal failure requiring renal replacement therapy. Acute renal failure in patients with cirrhosis is characterized by rapid decline in glomerular filtration, perturbation of extracellular fluid volume, electrolytes and acid-base homeostasis, and retention of nitrogenous waste from protein catabolism. The definition of acute renal failure in patients with cirrhosis and ascites is those patients who do not have baseline renal impairment, any increase in creatinine by more than 50% of the baseline to greater than 1.5 milligram per dl is defined as acute renal failure. Patients with pre-existing renal impairment, increase in serum creatinine by more than 50% above their baseline is considered as acute renal failure. The types of renal failure are mainly pre-renal. The common example of that is dehydration, secondary to lactulose overuse, or GI bleeding. And then hepatorenal syndrome, which is a functional pre-renal state, and it is seen in 28% of the patients in a study of 354 patients. The other causes include intrinsic renal failure, which include acute tubular necrosis, glomerulonephritis, and interstitial nephritis. Post-renal failure, mainly due to urinary outflow obstruction, is rare. Most of the time, because of splanchnic vasodilation and central hypovolemia, the kidneys think that there is a hypovolemia and they are maximally autoregulated. So whenever there is a second hit, like intravascular volume depletion and hypotension, severe sepsis, type 1 hepatorenal syndrome, radiocontrast agents or drugs, they further decrease the renal blood flow, which decreases the glomerular capillary pressure and result in decreased GFR or renal failure. Hypovolemia is one of the most common cause of prerenal failure. In patients who present with GI bleed, 5% have early renal failure that lasts for less than 7 days after index bleed. Dehydration secondary to diarrhea can also result in hypovolemia. Then again, arterial hypotension secondary to infection sepsis can result in prerenal failure. Patients with spontaneous bacterial peritonitis and renal failure, at the onset, 20 to 40% have renal failure, and subsequently septic shock and subsequent renal failure develop in 10% of patients. Hepatorenal syndrome is one of the most ominous complications of patients with cirrhosis and ascites and carries a very poor prognosis. The annual incidence of hepatorenal syndrome is 8% in patients with cirrhosis and ascites. Hepatorenal syndrome is of two kinds. Type 1 hepatorenal syndrome is defined as serum creatinine greater than 2.5 mg per deciliter within 2 weeks. The median survival after the onset of type 1 is 2 weeks. It could be spontaneous or precipitated by spontaneous bacterial peritonitis, large volume paracentesis, or severe alcoholic hepatitis. In the parentheses are the rates which are seen with the associated precipitating factors. Type 2 hepatorenal syndrome is a gradual decline in serum creatinine to greater than 1.5 mg per dl, and the median survival in these patients is around 6 months. The 3-month survival is 70%. The diagnostic criteria for hepatorenal syndrome include serum creatinine greater than 1.5 mg per dl, no improvement despite diuretic withdrawal and volume expansion, absence of shock, use of nephrotoxic drugs, or parenchymal kidney disease. The other minor criteria include urine volume less than 500 milliliter per day, urine sodium less than 10 milliequivalent per liter, urine osmolality greater than plasma osmolality, urine RBC less than 50 per high power field, and serum sodium concentration less than 130 milliequivalent per liter. This cartoon shows the therapeutic options and aim of therapy for hepatorenal syndrome. So, liver transplantation is curative for hepatorenal syndrome, but as I said in the beginning, there are 17,000 patients waiting for liver transplantation and only a third of them gets transplanted. So, it's not an option for everybody. Plus, we have to use therapies to bridge them to transplant. Because the pathophysiology is splanchnic arterial vasodilation and decrease in cardiac output, various medications like intravenous splanchnic vasoconstrictors, in addition to plasma expansion with intravenous albumin, can reverse hepatorenal syndrome. And then lowering the portal pressure by creating a TIPS shunt may also reverse hepatorenal syndrome. So let's talk about vasoconstrictors and albumin. Vasopressin analogs are terlipressin. This agent is not available in the United States, so we cannot use it. The other thing that we use commonly in these patients are somatostatin analog plus minus alpha-1 adrenergic agonist, mainly octreotide and midodrine, titrated to increase the mean arterial pressure at 15 millimeter of mercury. The dose of midodrine is anywhere between 7.5 to 12.5 milligram TID, and the dose of octreotide is 100 to 200 micrograms sub-Q TID. In the studies, they have used these drugs for 15 days, and the endpoint was either reversal of HRS to stop these medication or 15 days. There is some data in the form of pilot study which has shown that noradrenaline in conjunction with albumin can also reverse hepatorenal syndrome. TIPS may be an option in very highly selective group of patients. As you know, that model for end-stage liver disease score, also called as MEL score, was designed to risk stratify the patients undergoing TIPS procedure. So high bilirubin, high INR, and high creatinine were the independent predictors of 3 months mortality after TIPS procedure. So anybody who has high MEL score or high bilirubin, high INR, and high creatinine are not good candidates for TIPS procedure. Patients with MEL score greater than 18 are too ill to undergo TIPS procedure. Liver transplantation is a treatment of choice for patients with advanced cirrhosis. So this is the equation for MELD score. Creatinine, bilirubin, and INR are the components of MELD score. MELD score was instituted in 2002 to decrease the waitlist mortality. And since then, the number of patients undergoing liver transplantation with serum creatinine greater than or equal to 2 mg per DL has increased by 25%. There is also an increase in the number of simultaneous liver and kidney transplant since the implementation of MELD-based allocation system. What can we do to prevent the acute renal failure in these patients? Spontaneous bacterial peritonitis, as I said, is one of the precipitating causes for acute renal failure. ASLD guidelines recommend use of albumin with antibiotics can prevent hepatorenal syndrome. So the dose of albumin is 1.5 gram per kg body weight on day 1 and 1 gram per kg body weight on day 3. The next thing is secondary prophylaxis for patients who already had an episode of spontaneous bacterial peritonitis. We can prophylax them with norfloxacin once a day or ciprofloxacin 750 milligrams every week. This will prevent spontaneous bacterial peritonitis. The other common thing that we see is these patients with ascites undergoing large volume paracentesis. If they're going paracentesis greater than 5 liters of fluid, they should receive 8 to 10 grams of albumin for every liter of fluid removed. That helps preventing acute renal failure in these patients. Then close monitoring of renal functions while they are on diuretic therapy for ascites and avoidance of medications like non-steroidal anti-inflammatory drugs. Most of these patients undergo CAT scan for surveillance of HCC, and the radiocontrast can induce acute renal failure. So the major risk factors for radiocontrast acute renal failure include pre-existing renal insufficiency with creatinine greater than 1.5 milligram per DL or EGFR less than 60 milliliter per minute, and those who have history of diabetes with diabetic nephropathy. To prevent radiocontrast-induced acute renal failure, you can hold the diuretics 24 hours before and after the procedure. You can hydrate them intravenously if they are in the hospital or orally if they are coming from home for 12 hours before and after the procedure. In our institution, those who have creatinine greater than 1.5, we usually give them N-acetylcysteine 600 milligrams orally, time 4 doses. And this is the dose listed for 24 and 12 hours prior to the procedure and 1 and 13 hours after the procedure. Nephrogenic fibrosing dermopathy. It is one of the condition which is seen in patients with renal failure who are on dialysis. It is associated with gadolinium exposure. The reported risk of this entity is 2.5 to 5% in studies of approximately 400 to 500 dialysis patients. FDA has black box warning for patients at risk, and they are acute or chronic severe renal insufficiency with estimated GFR less than 30 milliliter per minute, or acute renal failure of any severity due to hepatorenal syndrome and in perioperative liver transplant period. There is no proven therapy for this condition. At University of Michigan, if patient on dialysis has to undergo MRI, an informed consent has to be signed by the patient. The take-home points from this lecture are patients with cirrhosis and ascites with any evidence of renal insufficiency should be referred for liver transplantation sooner than later. Octreotide and midodrine with albumin may reverse hepatorenal syndrome and serve as a bridge to liver transplantation. TIPS is usually not recommended for patients with HRS. Measures should be taken to minimize the risk of renal failure in patients with cirrhosis. How can we do that? By using albumin with antibiotics for SBP treatment, albumin replacement for greater than 5 liter large volume paracentesis, and avoidance of NSAIDs. Thank you.